刻になりましたので、本日の東京大学医学教育セミナーを始めたいと思います。本日もスピーカーは多佛大学の元副学長医学部教授であられるメアリー・リー先生にお願いしております。今私は東京大学の認証評価の業務をいろいろと手がけているんですが、いろいろと、業務の中で、悩むところも多くてですね、その度にリー先生には相談を申し上げているというところなんですが、特にその、学習者評価というテーマはですね、常にこの医学教育の文脈の中で皆さんが悩まれて、どこまでやればいいのかというふうなことでいろいろ考えるところだと思いますけれども、そういう中で、その多仏大学でのいろんな取り組みについて、あるいはアメリカの認証評価の枠組みと絡めてですね、ちょっと状況をご紹介いただこうというふうに思っております。
Thank you so much, Dr. Onishi. Welcome to all of you. Thank you so much for coming this evening. And I think as you may gather from, if you've been looking through the handouts, I will be providing some information about student assessment, but I also have some activities that I would like each of you to participate in. So I do hope, I do see you somewhat in clusters. And I hope that you will be talking with your colleagues during part of this session. So I couldn't resist. Yesterday was a beautiful day, and I happened to walk by Todai's beautiful ginkgo tree, which I absolutely love, and it's just a fabulous color right now. This is actually part one. Today we're going to be focusing on student assessment, and the next session in December I will be focusing on the use of assessment by faculty and programs. But today we're more specifically focusing on students. So as before, I want to make sure that we have the opportunity to exchange ideas, and so that's why there are some activities. So have you talk with each other, but also share your thoughts with the rest of the group. I'll be describing some assessment purposes and methods, obviously in an hour and a half. The area is quite huge, and so I'm only selecting certain things to discuss. I was asked to focus on soft skills. Things like communication skills, professionalism, ethics. These are things that are more difficult to assess, so I'll be focusing most of my time on that. And as I mentioned, we'll do some hands-on activities. And then hopefully at the end of this session, you'll have some ideas that you can bring back to your own program. So I just want to start off and have you think about, why do we assess? Why do we assess? So I'm just going to have you talk to the person next to you. Why do you assess? seems like you probably have a lot of ideas. So let's write some of those down. So what did you come up with? What are some reasons for assessment? Why do you assess?
We just talked about with assessing, we cannot measure the levels of the, for example, learning or activities. And only by assessing, we can know the gap against the objective and kind of level. And also another opinion is with assessing, we cannot detect the delay of learning, for example. If we can identify such delay or gap, then we can take measures. So.
Find gaps to remediate. Yeah. And what about over here? Back here first. Yep.
To know whether or not the student achieved the objectives, goals.
As a motivation for students to learn.
Mm-hmm. Very powerful motivator.
Only. Sometimes.
Yeah, sometimes. Yeah, and what about here?
That's also what I'm talking about.
Motivation. Mm-hmm. Yeah. Any other?
Yeah, well, the teacher would like to know whether we're doing right thing, how we are doing.
So how are we doing?
Right.
How are we, the faculty, doing? How are we getting through to the students? Yeah, so, you've really picked up, the major reasons for assessment. And, I'd like you to keep those in mind as we go through the session, thinking of the goals, and the goal being really finishing medical school is their immediate goal, right? And all these different assessments we do on the path to that goal, these assessments are ways, just as you said, we're trying to measure where they are in relation to the goal. Have they met that objective? And there are various objectives along the way. And, are we able to motivate students while we're doing this? And can we get feedback from these assessments to see how effective we are in teaching the students? And, I think that we often think of, we just have to get them to graduate. But what I wanted to emphasize is medicine is really a lifelong journey. And we keep talking about trying to motivate students to keep learning, and we have to remember that we're not teaching them just to climb that first mountain, right? We're really teaching them, giving them all the skills, knowledge, and attitudes so that they can climb their own mountains. And they're going to be meeting all these different challenges throughout their career, and what we're really providing them with are all the tools to do that. So if we think of the goal of medical school, we have to think of the students reaching that goal as our outcomes. Our students are our program's outcomes. And it's important to think about the outcomes as being really shown through your mission. And so I think it's important that the outcomes of your curriculum, must support whatever your mission is. And so to think about for each of your programs, are you focused on research? Are you focused on clinical? Are you focused on both? Because that will change the outcomes that you're looking for. The other thing is we start with the students, and this is something that's being discussed a fair amount in the United States. And if faculty are saying we don't have the right students, they're not this, they're not that, are we doing the best we can to pick the students we feel should be going through our programs? And so I would say at the moment, we are really picking assessment-driven students. I mean, the testing systems we require, the hurdles that we require students to jump over before they can get into medical school, it's not surprising that, faculty complain, oh, the students, all they think about are the tests. Well, that's how they got into medical school. And so, I think it's important for us to think about, if we don't think the system is working, we have to change the system. Because the current system is optimized for whatever result you're getting right now. And so the thought is, can we select better? Can we train better? And I think that a number of people brought to my attention issues of research misconduct. This is a huge issue in the United States as well. And we're constantly looking at, is it a matter of training? Did you just admit people who don't have the right morals? Or is the system really encouraging or supporting misbehavior? And are there ways that we can make better choices and also train better? So, I'm not going to dwell on this, but I just want to make certain that folks are aware that there are many different kinds of selection techniques for admissions to medical school that are being tried now. Things like the multiple mini interviews, behavioral-based interviews to try to get at how students think about difficult problems. Some are even using what are called admission OSCEs, difficult scenarios and seeing how students react. And also group interviews, rather than basing their acceptance on a single interview, actually having multiple people interview either together or sequentially. So, someone mentioned earlier motivation of students for assessment. And I completely agree with this, and there's certainly plenty of literature that supports the fact that assessment drives learning. And if you don't change your assessment methods, you're not going to change what's happening with the students' learning. And so I would like us to take a moment and think about if, we talk about knowledge, skills, and attitudes, and we say they're all equally important. Are they really equally assessed? Can you really say right now, if you feel that knowledge, skills, and attitudes are equally important to make the complete physician, are we really assessing them equally? Seeing it, yeah. Certainly we have not. And we recognize this in our curriculum reform, that yes, we were testing knowledge, and mostly facts. We were not testing reasoning, even though we said that we valued reasoning. We were really just testing facts. We said we were interested in professional behavior. We were not assessing or grading students on professional behavior. Faculty said, oh, you can't assess that. And, I will tell you that if professional attitudinal behaviors are not explicitly stated as expected by the students, and if you do not assess them, the students will ignore it. Absolutely. And you will miss the opportunity to reinforce the behaviors that you want. So if assessment drives learning, how can we use assessment methods to promote responsibility of students for learning communication skills and professionalism? So this is where I'm going to give you some examples. And I know that you're all quite familiar with both summative and formative assessment, but I just want to emphasize summative assessment being assessment of learning that has taken place versus formative assessment, which is assessment for learning, to help the student learn. And so with behavioral assessment, it's important, students need to know what the expectations are. And you need to integrate those attitudinal behavioral assessments right from the beginning. So I can tell you that, you know, our students, you can tell me whether you have the similar problems here, but I can tell you that in the United States, our students enter medical school from college. College is, for many of them, first time away from home. They have incredible freedom. They dress any way they like. They can say anything they like. They behave any way they like. And so they come into medical school inappropriately dressed. You know, first time they come to lecture, you know, their legs are up on the back of the seats, and, you know, body jewelry, on and on, you know, inappropriate clothing. We have to socialize. We have to socialize them into the profession of medicine. Maybe you don't have as much of a problem here, but I can tell you it's an issue in the United States, and we have to socialize the students into the profession of medicine that starts from day one. We said, it's great, you know, folks all came from different colleges, you're now in medical school. You now represent both our medical school and the profession of medicine wherever you go. You know, it's no longer you're there representing yourself. You are now representing the profession. And so reminding them of this, not just within a course, but just through the daily way that education is conducted at our school. We remind them that they are professionals, and we treat them as professionals, and we also call them on any behavior where they're not acting professionally. And I can't tell you how critical it is, and how, you know, at the beginning they're surprised, you know, they don't really think about it, but then it becomes habit. And those professional behaviors really get absorbed. So, addressing difficult topics. We found that in talking about some of the difficult ethical behaviors, students in a large lecture can be very reluctant to volunteer their thoughts. And so we have a large medical school, 200 students. As I mentioned last time, lectures typically are optional with the exception of certain programs, and ethics, some ethics case conferences, those are mandatory. And they discuss very difficult patient cases. And it's really interesting. We have a very diverse student body from many different cultures, different countries. And it's really interesting to see how different the students think about these ethical issues. And so being able to identify, you know, through things like an audience response system where they don't have to reveal publicly what their thoughts are, it's much better at collecting information about controversial topics. You can then, with that data, help you guide how you're going to design the small groups to really get into those discussions. So, you know, we found that extremely valuable. And discussing ethical issues face-to-face versus online. You know, we first started thinking about, you know, does it all have to happen face-to-face? You know, what will we lose doing some of these discussions online? And what we found is actually, for some of these discussions, they were even richer online because students who were reluctant to speak up, they had more time to think about it. They could write their thoughts down more carefully. And so we actually found that mixing online with the face-to-face small group discussions was actually better. And that was a surprise for us initially. So when you think about all the integration that happens across our curriculum, last time I talked about how we try to integrate all the course content. We don't have siloed courses. They actually, there's a huge amount of integration. We try to integrate the communication skills and professionalism throughout. And an example of this is everything in the curriculum is assessed. We assess the students assess us, they assess the program, they assess the units, etc. And actually, part of what we train them in is how to give feedback. So in problem-based learning, I don't know, actually I forgot to ask whether you do that in your problem-based learning here, but a really important piece of problem-based learning is for the students to learn how to give feedback to each other and also to their faculty member, which is obviously a little bit scary at first for them. How can they give feedback to their professor? But that's part of their professionalism, learning how to give feedback in a constructive way. And so as they are evaluating all their courses and programs, we actually, even though it's anonymous, when they have a course unit, they can evaluate the lecturer, they can evaluate the small group leader, the content, whatever. We actually show them examples. Here's an example of constructive feedback, and here is feedback that really is unprofessional and not helpful. And so they're constantly getting feedback about how they're giving feedback, and also what's critical with that is letting them know what you're doing with the feedback. Because if you just collect the feedback but don't tell them what you do with it, they're going to stop giving it to you. But we also tell them, based on your feedback, this is what we're doing in response. This is what we're changing in response to your feedback. It's not that you have to listen to everything that is written down, but you say, these are the trends we see, these are the things we're going to address. Here, this seems to be a concern, this is why we cannot address it right now. And I can't tell you how powerful that has been. Engaging them in the curriculum, as well as really teaching them how to give constructive feedback. And when the students know that they're going to be assessed not just on simple performance, here, okay, you're teaching CPR. If they know that they're also being assessed on how they interact with their peers and their professional attitudes and behaviors during that skill set, they're going to pay attention to that. So just want you to think about whatever the performance outcome you're thinking about, whether it's knowledge, skills, or attitudes, making sure that you align the assessment with whatever outcome you're looking for, and think about whether you're really creating a formative or summative assessment, and then why is that assessment important? What are you really assessing? How are you going to assess it, and when are you going to assess it? So I just want to give a quick example of communication skills, and this could be any part of communication skills, but the outcome is we want them to be able to speak to patients from many different cultures. And so the summative evaluation is going to be an OSCE where we have a trained standardized patient who can assess whether or not the student can work in a culturally sensitive manner. And the plus F here means there's also going to be a faculty assessment with that. And so that's going to be our summative evidence that we need to show that there's mastery of that communication skill. We really emphasize formative assessment. There's formative assessment throughout the curriculum. And so this can involve assessments from their peers, from faculty, from the standardized patients, but also we teach them how to self-assess. And again, think of climbing the mountain. You're giving the skills for them to really work on their own. And so many different kinds of formative assessment, whether it's on-site practice, small groups, they're writing in a journal that's being assessed, the standardized patients, and then thinking about the foundation. What are the baseline knowledge, skills, and attitudes that they need before they can actually learn the skills and be tested in the summative OSCE. And so in this case, we use problem-based learning, we use the interviewing course, we use the clinical skills course. So this is your first activity. You take that other sheet that looks like this, and what I want you to do is just take a moment by yourself and just focus on the outcome. We're going to do other parts of the chart later, but for this moment, just focus on the outcome. Just pick any outcome. If you are currently teaching a course that has some behavioral or communication skills attached, or if not, think of a way that you might be able to incorporate behavioral or communication skills outcomes to your course. And so I want you to just take a moment, think about an outcome, and jot it down in that upper right-hand area under outcome. By the end of the unit, the student will be able to do what? Something that you're going to be able to assess. When you're finished jotting it down, I'd like you to explain your outcome to a colleague. Focusing on why you think that outcome is important. just had you think of an outcome related to communication skills or behavior. It could be from your course, or you could add it to Okay, we'll fill out the rest of the form later, but I just wanted you to focus on outcomes right now and really to just have some sense of some outcome as we go through the next part of the presentation. I'll give you another minute to discuss it.
The end of this unit.
Okay, so if you look at your outcome, I think some important questions to ask yourself is, I asked you to talk about why you think that assessment was important and what you're actually assessing, how you're going to assess it. I think that we often fall back into the same methods. And it's important to really diversify, really change the types of methods that you're using, and also think about the timing when you are assessing. And if you are thinking more of formative assessment, and this is what we really try to incorporate much more of in our curriculum, the timing actually becomes much more frequent and also really intentionally paced at a way to really help the students learn. And so, we already talked about thinking about matching the assessment with your objectives, but I think just from the experience I certainly had working with many faculty, we often do not weight the assessment based on importance. The knowledge based, the simple multiple choice questions are easy to do. We tend to rely on those heavily, even though we recognize that it's really not the best way of assessing what we truly are interested in assessing in our students. Is it instructional? And so the assessment doesn't need to be just summative, and one of the most common complaints I previously heard from our students is we're not getting any feedback. And so the assessment really has to support learning and help the students identify where their deficiencies are. This is something you had mentioned at the beginning, help the students, help you find the gaps and help you remediate, but also help the students self-identify what those deficiencies are. And is it motivational? Are we using assessment to really instill that lifelong desire and ability to climb mountains? And the other piece that we forget is, are we reinforcing and building on other parts of the curriculum? And previously, our curriculum was very traditional with each course really by itself. But with our integrated curriculum, the faculty really need to pay attention to each other. They need to know where their piece fits in the whole curriculum. There's a lot more coordination. When you start integrating, you really need to coordinate across the faculty. So we designed by working backwards from the goal of clinical performance. And if you think about that mountain again, we're preparing them for internship and residency. And in order to do that, they have to function at a certain level in 4th year. And to function at that level at 4th year, we have to get them to a certain level at 3rd year. And to function at 3rd year, we have to, get them to a certain level by 2nd year, et cetera, et cetera. And so we really focused on formative assessment. And so throughout each course, through each unit across the curriculum, we really thought about how our assessments would help them learn and really identify their strengths and gaps, focusing on guiding them to mastery, and really combining self-assessment along with peer or faculty assessment. And previously we really did not use very much self-assessment, but it's extremely powerful, and the students are motivated. They want to pass all the exams and all the ways we're assessing them. If you give them the tools, they will continue to learn until they have mastered whatever it is. And so we can also, as we mentioned earlier on too, is that it can give us feedback as faculty to make real-time course revisions. We have a system where we get feedback from the students as a course is going on, and so we can actually make revisions in the program as the students are moving through the units, so to ensure that we really maximize their learning during that time. And students love that because they feel, the curriculum is very responsive to their needs. And linking the link between assessment and feedback, again, assessment of learning, measuring the learning that's happened at a particular point in time, versus the feedback we give to the students for learning. This is information that we give back to the students so that they can it helps them master the material. So I'm going to take a few minutes and talk about our standardized patient OSCE program and try to imagine this, taking a radiologic or anatomical analogy here. This is a sagittal cut through our curriculum. So it's really just one slice. And so it's very hard to convey the complexity of the curriculum through this slice. But, I think that, it's one place to get some idea of how we built the curriculum. So we use standardized patients and OSCEs across the entire 4 years. And there is a complex mix of both formative and summative assessment. So there are times when they use the standardized patients for practice, for actually learning skills like interviewing or physical diagnosis. But we also use standardized patients for final summative evaluations to demonstrate mastery at the endpoints of each of these programs. And some of these overlap. The interviewing and physical diagnosis have to happen before they go to their competency-based apprenticeships. This is where they actually go to real clinical offices across New England, actually. And the other thing is that physical diagnosis happens concurrently with anatomy. So they're learning, they're doing integrated anatomy, physiology, along with clinical skills, all together. And so at the end of your handout, I actually added about 8 slides giving a lot more detail on each of these programs. And certainly there's much more I could provide, but I wanted to keep the amount of information down. But if you're interested in a particular part of this, I'm happy to share, happy to share more information about any aspect of this. But I think the important thing to see here is that each of the reason I put a two-headed arrow across the 4 years is that we have constantly evaluated the program backwards and forwards. Because our ultimate goal is the graduating student, and we see, okay, do they have adequate skills? If not, okay, this is what we have to do in year 3. We've done this in year 3, does that really make a difference in year 4? And back and forth, we're looking at, okay, to prepare them for year 3, you know, does their apprenticeship in primary care and their program in clinical reasoning, does it really prepare them adequately to function fully in the clerkships? You know, we're constantly going back and forth, looking at the student assessments and program assessments, and making adjustments in the program. And so by step 4, our students actually typically take it right at the end of year 3. And they need them for residency applications, 97 and 90%, 99% pass the first go-around. And I think, you know, large part because of the amount of practice they get. But these skills are essential for the rotation, so it's great that they get it done before they start their 4th year. So I do want to emphasize that, you know, all these OSCEs are only one mode of assessment. And so as good as they are, it's just one method, and every method has its pluses and minuses. And I want to emphasize that we need to use OSCEs with other modes of assessment, particularly for clinical skills, which are very complex. And different learners are going to be able to demonstrate their mastery with different modes of assessment. And so it's really critical that we use complementary assessments, both formal and informal, immediate versus delayed feedback from the assessments. It can be faculty to students, faculty to a group or a team. Peer-to-peer, we use a lot of student-to-student assessments, residents to students, and have the students actually, we give them the tools where they can start initiating some of the feedback and assessments from the residents and faculty. I just wanted to show you what our skill center looks like. This is the central orientation and demonstration space. You know, typically just to orient them to what's going to happen in the OSCE or demonstration or whatever the session is. This is one of the corridors. This clinical skills center actually takes an entire floor of a building. It's 9,000 square feet. I'm not sure what that equates to your measurements, but it's quite large. There were 2 main corridors on either side, and that big conference room was in the center. And so these are critical because with the timed OSCEs, you have a monitor at the end, and you know, with a little stopwatch, and they're running down the rooms, knocking on the doors to give the students warning of when, you know, time is up for them to move to the next station. And you'll see the flexible room formats. You see these grids in the floor. So these walls are movable, and that's critical for us because with so many students, it's hard to recruit sufficient faculty. So these rooms, particularly in the demonstration times, you can see multiple rooms are open. And so one faculty member can actually manage 4 rooms simultaneously with the walls open. And obviously the walls then get closed for the final OSCEs. The faculty assessments during the OSCEs are a complement to the standardized patient feedback. It can be immediate or delayed, and all of the summative OSCEs are videotaped, so that if there's any question about passing, they can be reviewed. And we also evaluate clinical reasoning. So the faculty are observing students while they're doing the OSCE, and then for the students that they have observed, they actually correct the write-ups and look for their clinical reasoning skills. And the faculty can either be in an observation room, which are attached to each of the rooms, or what we found was, again, because of the difficulty recruiting faculty, they can actually do this remotely now. So we have faculty from our affiliated hospitals that are quite far away that actually can monitor the students real time while these are happening. So sample competency, this is a very basic one, just showing patient-centered perspective, what the standardized patient is trained to evaluate. Did the student elicit or listen to my beliefs, concerns, and expectations about illness or treatment and was non-judgmental? These seem very general, which they are, but the standardized patient is actually trained in very specific cues that match these competencies. And so this is the general competency, but then there is very specific training around what the standardized patient is looking for during the encounter. And I can tell you that we now have data on over 10,000 student standardized patient encounters. And so with all of that data, we can now identify very easily if there is variation due to a standardized patient. You say, well, the standardized patient is relatively new, they're not that consistent yet, et cetera, et cetera. We can actually see that in the analyses of the encounters. And with our summative OSCEs, we only use the most experienced standardized patients, so we don't have that kind of variation. So, I think that it's critical to think about how each of those units, when you're thinking about behavioral or professional communication skills, how those units fit into the whole. And I just wanted to mention here the issue around clinical evaluation, and I think many of you are familiar with this, but I just wanted to emphasize the problems with straight clinical evaluation, which students say are subjective, which they are, and we call it the halo or horn effect. Halo being angel halo. Student appears good on day one. The rest of the time they can do no wrong, no matter what they're doing, and the opposite can take place as well, where we as faculty can be biased in the way that we assess students. Once we've decided, oh, that's a strong student, we mark everything strong, or they're a weak student, we mark everything weak, without really being very objective on how we're making those assessments. And so it's important to know that those biases can be mitigated with multiple evaluations. So that can either be multiple faculty evaluating the student, or multiple modes, or ideally both. Different modes of evaluation as well as multiple instances of evaluation. So for instance, in our medicine clerkships, students will have over a dozen different faculty and residents evaluating them. So, you can clearly see when a student is having difficulty. So students need to know what and how they'll be assessed, assessment for learning. So the inputs for self-assessment, if you think about it from the student viewpoint, the student is getting information from the faculty online, different ways that we use online materials, and a lot of information from peers. And the student says to themselves, based on the goals and feedback I'm getting, what do I need to learn? And so, I think we often forget to think about assessment from the student perspective. And are we really giving them clear expectations, and this is another thing, other than students saying, I'm not getting enough feedback, the next thing we hear is students say, I don't know what the expectations are. So these need to be very, very clear. So focusing on the goals, which includes the expectations, and very specific feedback that the student can get to improve their learning. Okay, so with that as background, now we're going back to your diagram. And now I want you to consult with your colleague about what summative and formative assessments you need to provide evidence that the student has mastered whatever objective you named. And if you have time, you can also do this far left block, which is what are the foundational units that you could integrate with to support the learning of your objective. But the main thing I'd like you to focus on is looking at either formative or summative assessments. What kind of evidence can you collect to show that the student has either learned, so it could be formative, is learning that outcome, or actually has mastered that outcome. So you can consult with your colleagues, you can help each other figure out what that evidence would look like. And I'll give you till 7 o'clock to do that. So it's about 7.5 minutes. Okay. Would anyone like to share what came up in your consultations? Either things that you've discovered that are new, or roadblocks, things that you said, oh boy, this is a tough problem, can't figure out what to do with this. Would want to share some issue that came up during your discussion? Yes.
I'm Harumiano from University of Tsukuba. We just discussed the logistic problems. If you have a large number of students, it's kind of hard to implement realistic, ideal assessment methods.
Yeah, and how many students do you have?
In our medical school,
Mm-hmm.
It's about the same. Throughout Japan, we have either 100, 120, or 30.
Mm-hmm.
It's about the same.
Yeah, yeah. And so our classes are 200 each, and so it was quite a challenge for us to start these programs. And again, they didn't happen overnight. We had to build them slowly, and also train faculty, recruit faculty, develop the programs, test the programs. So it did take a long time to get it to where it is right now. The other thing that I forgot to mention, which would probably make all of you swallow hard, is our budget for our OSCEs now is over $500,000 a year. So that's over 60 million yen a year as a maintenance budget.
Is that for 4 years?
All 4 years, all 4 years, yeah. Gosh, if that were per year. It's already, it was pretty tough to build that budget. Again, I mean, we started very small, you know, $20,000, $50,000, which is still a lot of money, but compared to $500,000, it was a small amount of money. You know, we started very small and slowly built the program. Yeah.
Can I ask a question about, this is also the question about the numbers, because we're not talking just about the size of the medical school, but in the pictures that you show, it looks as if a teacher is teaching 4 or 5 students at a time.
Correct.
And what I was thinking of is more my situation where I'm teaching 30 at a time.
Right.
So that also limits how and when you can do assessments, and and it's not just a question of the number of students, but the number of hours you have with them.
Right.
How much of the total are you spending on assessment? Because I know that when I began teaching, I was spending too much time on assessment, and so I stopped, basically.
Yeah.
How does that work out?
Well, you know, it's always a balance, and you know, this is part of that whole feedback loop of figuring out, you know, are you giving enough feedback to the students? Are you getting enough feedback whether, you know, your methods are working? And even though it looks like those are small groups, many of our groups are actually medium groups. You know, so those students are working in clusters of 5 to 6 students, but one faculty is actually managing 4 rooms. So they're actually managing, you know, anywhere from, you know, 20, 26, sometimes 30, occasionally 40 students at a time. And, but the students typically, the way the different modules are developed, they're developed for small groups. And the students are very used to, you know, whether through problem-based learning or the team-based learning or, you know, throughout the curriculum, they're working in small groups. And they're facilitated in different ways. And so the students actually learn how to facilitate through problem-based learning. And so some of the formative pieces, they can actually manage, and then the faculty members floating to make sure that the groups are progressing appropriately. And, you know, the faculty members there as a resource. Obviously, earlier in the curriculum, when the students really don't know how to do that as well yet, there's a lot more guidance. And so, you know, there's more intensive work up front to get them to the point where they can work in these groups more autonomously with faculty help.
But, excuse me, this still sounds extremely abstract. And my question about, I understand that everybody has to be evaluated, but, and you can't wait until the end to say, you know, you pass or you fail. But whatever the unit is, if you're looking at teaching in terms of per week or per month or whatever, how much of that time are you devoting to the assessment and how much to all the rest?
Well, it depends, you know, there's no formula. It depends completely on your objectives and what your unit is expected to do. So maybe as a more concrete example, I added this later, so I don't think it's in your handout. But in physical diagnosis, that might be too small for you to see, but you know, so physical diagnosis runs over several months, and there are different kinds of assessment. So they have to do reading and online quizzes. So Before every unit, they work in groups every week, examining each other, and they come 25% of the class at a time, so I guess that's 50 students each night for several hours, and they're working with, 8 or 10 faculty show up each night. But they are required to do reading, and they actually have to do an online quiz before they show up to the class to make sure they're prepared. And if they do not do that online quiz, it's part of their final grade, and so they lose those points if they don't complete the quiz before they come into the session. So, and then there are hands-on practical assessment sessions where the students get these checklists. They learn how to actually do those parts of the exam. They get guidance from the residents and faculty. There are also task trainers and mannequins that they can use. And so they're given, here are the expectations, these are the skills you're supposed to learn, here are the resources to do it. And by this time in the curriculum, you're going to get, they get 2 formative times with standardized patients for their physical diagnosis so that they can practice the physical exam prior to the end of the program, where their 20-minute encounter with the SP is 25% of their full grade. And they have to pass that portion in order to pass the course. And then in between, they have cumulative exams around the factual information, because again, they have to be able to correlate all the physical exam with the anatomy and the physiology, and all of those exams are cumulative, meaning that all of the examinations include all parts of the curriculum up to that point, including lectures, textbook, syllabus, and practical sessions. So that's, I don't know if that's a little more concrete in terms of what is being done.
It sounds to me as if you're testing them all the time. And in between, when is there time to actually do the stuff?
Well, again, it's hard unless we go day by day, but these assessments and the timing of these assessments actually was a real back and forth with the students. And so we actually worked with the students in terms of what worked for them, in terms of motivating them, and some of them said, frankly, I need the test to make sure I'm staying on top of this, because if you don't test me enough, I wait to the last minute and I can't catch up. And so we actually worked with the students to find the optimal testing sequences and intervals. And we're constantly getting feedback, and they change year to year. Some years, students like more tests, some like less. But after you've done this for several years, you actually get a sense of what's a good middle ground that works for most students. And so it's a combination. Yes, they are assessed a lot, but the majority of it is formative, and that's critical. And it's formative, preparing them for the summative exam that they have to pass, because there's only one route to licensure. And if they can't pass those final exams, they can't get a license, and they've spent 4 years of their life without being able to practice medicine. So, but the majority of these are formative. Other issues that came up? I mean, that was a great question. It's an important one. Other issues or things that you'd like to share with the group?
So we talked to assess the students' ability to communicate with patients with compassion and empathy. But we talked about the dilemma that we assess very strictly. We do OSCEs and 360-degree assessments or something like that. Students perform behavior, but internally they don't feel compassion, but they can pretend in behavior. So assessment drives such pretending in some aspect. So what do you think about it?
Well, it happens, for sure. And I think, these are smart students, and if you're assessing them in a particular way, and if they learn what the code is, oh, this is how the standardized patient is going to evaluate me. I have to say this in order to demonstrate that. They'll learn it very quickly. The hope is that the majority of the students that we are admitting to medicine actually are compassionate, and that we are helping to reinforce their compassionate behavior. So we feel that we're reinforcing positive behavior as opposed to uncovering misbehaving. Although that happens, and we want to be able to uncover that as well. And I have to say that we're blessed with a wonderful dean of students. She's been at it for a long time. She is really compassionate herself, but also very tough. And if we find a student who is faking, and actually this occurred one time while I was dean for education, it was a very difficult problem. But we actually finally were able to document something that he was dismissed from school for. It was being made aware, because it did come up on his assessments, and we followed through. And there was a misstep, which was sufficient for us to dismiss him from medicine. But you have to assess. You have to assess in order to be able to uncover that. If we were not assessing professional behavior, we would not have picked that up because it was extremely bright. He did extremely well on all of the knowledge-based assessments. But there were all these little issues on his behavioral assessments. Other things that folks would like to share? Other problems, it's a tough area. Other issues that folks came up with, like the additional consultation on?
I'd like to comment on professionalism education, which is really a hot topic currently in Japan. Due to the cultural differences between the Western countries versus Oriental or Japanese unique culture. Do you have any comment on that? Because I have a colleague who is doing professionalism education in Arabic countries, and they're trying to compare the differences between the Western versus Arabic context.
Yeah, I think that each country, and this is something that extends to the accreditation standards for schools, is that the standards need to be consistent with your own culture and norms. And so, I'm telling you the story of what we do. You need to take that and translate whatever seems useful to you for your situation. We can't dictate, what that looks like. And so, my hope is that by just giving you some tidbits of our story, that there may be ideas there that you feel that you can use But the professionalism issue, professionalism is really about cultural norms within the community of practice. And so, for here in Japan, I don't know how many regional differences there are, but in the United States, there are a lot of regional differences. And so there are certain things that are national norms and certain things that are actually community-based norms. And we also have to distinguish those. And that gets very complicated in the United States, particularly because we have so many immigrant populations. And I'll take domestic violence as an example. So domestic violence is a huge issue in the United States. And it was very interesting as we started putting domestic violence into our medical curriculum. And this was, I don't know, maybe 20 years ago, when we started incorporating it formally into the curriculum. We had discussions with the students. And the students actually, there was a broad range of reactions because there were students who came originally from countries where domestic violence was just considered, it's behind closed doors, it's a family issue, we should have nothing to do with it. As opposed to in the United States, by law, physicians must report any incidents of domestic violence. We legally are obligated to report incidences of domestic violence. So for those particular students, it's a difficult issue. We had to talk through many issues because it was different from the way they were raised, how to look at domestic violence issues as a family and a culture versus legally and as a professional. So those kinds of issues are really tough. But they're there, and we realize that as faculty, if we don't address these issues with the students, how are they going to make appropriate professional decisions if we don't talk about the difficulties of how to make decisions when you have a conflict between your personal beliefs and what you're professionally and legally obligated to do. So it's a tough issue, and I don't know what is happening here in Japan in terms of looking at how to define professionalism here. And I know that there's a lot of discussion around the research ethics and the number of cases that have happened, and what to do about that. Well, I wanted to have you have the opportunity to think about your outcome and the summative and formative assessments, and see it's not easy to do. I created just this very simple chart, for you hopefully to just get an idea of the broad structure of taking an outcome, thinking about the summative and formative assessments and where it fits in the curriculum. Because each of the pieces that we are responsible for fit into the larger whole. And so I wanted to take just another moment and have you, I had this slide up before, but I think it's a really important slide in terms of looking at what you wrote, what did you discuss, and thinking about, did you really define why you're assessing what you're assessing? And really defining what it is that you're assessing, how you're going to do it, and when you're going to do it. And when is how much is too much, how much is not enough, and if we keep in mind the goal, the outcome of learning and mastery, and ask ourselves, is this assessment really helping that? And the other thing is, we forget to ask the students. And I have to say that's one of the things we feel that we do well, is that the way in which we engage our students in the entire process of assessment really engages them. You know, they know that we're not just testing them to test them to death. You know, we're testing them so that they can continually gauge their own progress against the goals, the ultimate outcome of graduating from medical school. So, you know, I'd like you to also just take a moment and think about how you might change your assessment methods to increase student responsibility for their own learning. And, you know, I think that, you know, I know that we certainly had very faculty-focused assessments previously. But, you know, with the amount of student engagement, the students themselves have come up with great ideas about how to improve assessments. And also, students have helped write exam questions. So for physical diagnosis, actually the instructor asked the students to all submit one question. And if the question was good, he would actually include it on the final examination. And the students, you know, took it as a real challenge to come up with good questions that would get included in the final exam. So, you know, we're helping the students make this trek. And, you know, if we do what we're supposed to do, you know, we really help them, you know, reach the goal. So, you know, as the final few minutes, you know, I'd like you to think about out of what we discussed, what do you think is possible as a next step, you know, for whether it's your own individual course or if you're responsible for a larger section of the curriculum, you know, what's possible? What's some takeaway? Hopefully that, you know, some idea that got sparked that you could bring back to your own program. So you want to share that with a colleague and then maybe pull some ideas from you at the end. Anyone like to share any thoughts that came up with your consultations? Anyone over here like to share any thoughts that came up?
I was talking like that.
we have to change the whole curriculum. Usually in Japan, one professor or teacher teach about one topic. Based on the stuff we learned today, I think we have to change the whole curriculum, or even one unit, to teach one subject, collaborate with other the staff, teachers or professors to make one curriculum. That's a hard part we have right now in Japan.
Yes. I mean, it's quite a challenge to make a major change, but it can be done. But it does take time. It does take a lot of time. And I think I mentioned the last time, it took us 2 years to design the new curriculum and then another 4 years to implement it. So year by year, because you have current students in the current program, and you have to just change 1 year at a time as the students are going through. And we actually started at year 3. You would think we'd start at year 1, but actually the major changes in our curriculum were we incorporated much more clinical training. And so we actually had to make the changes in year 3 first, and then move everything back. So, that first year was really difficult. Other thoughts? What else? What other thoughts come up?
So may I ask you a question? You said that you changed the year 3 assessment or curriculum, program.
Yes.
And did you change the promotion criteria for the faculty members for the year 3 students? Or assessment for faculty, actually.
What do you mean by assessment of faculty?
Meaning like promotion criteria.
For the faculty who were participating in the new curriculum.
Or teaching clinical medicine.
Yeah.
For year 3 students.
Well, we had already made changes. We previously had never had a clinician educator track. And so that had been incorporated actually prior to that. And so we actually needed a lot of faculty development. And so, definitely there were more clinicians moving through the clinician educator track subsequent to this, because many were engaged in the reform.
Is that what you mean?
Other comment? Anyone? Their view? Yeah, you're all set. Right here.
So in terms of the assessment of the compassion or empathy that you have mentioned, I think the example you described is to identify the students who are not professional, right? So, Son Sensei was talking to implement an assessment for such aspect of the students. But then, so I thought that the lesson I learned today are that when we say assessment, we instantly think the like ranking the student. But it's really difficult to sort of grade the student, he's more compassionate than this, right? So, so that's not the sort of assessment you mentioned. So, so I guess if we focus on such the professional behavior or thinking, I guess besides assessing the student at the end of unit, I guess we need some sort of scheme to specifically identify such student and follow through, as you mentioned. On the other hand, if this sort of assessment is to reinforce the student's good behavior or the way of thinking, it might be a good idea to do or repeat this sort of assessment at each end of each unit. We might do that. So I guess what we have discussed or learned today is that there are many ways to assess. So I guess the flexibility or the free way of thinking will be important.
Right. And I think, from what I heard, a lot of great ideas in there. And what I would encourage you to do, whatever you design, is to incorporate the student feedback. And so that, if you say, well, we should assess them at the end of, every unit, what does that really mean? And are those formative assessments where they feel, oh, this is where I'm getting feedback, so I know I can gauge what else I need to learn, versus summative feedback, multiple summative assessments, which may cause more stress and end up encouraging behaviors you actually don't want. And I think the students typically, when they know that their feedback is getting heard, they're more than happy to give you the feedback in terms of what's working for them or not. And when you start collecting this data, the noise in the data actually is pretty obvious. And it really helps you not react to a handful of vocal students. So with that, thank you very much for today's session, and I hope you'll join us in December, where we'll be talking more from the faculty and program perspective about assessment. So thank you very much.